Hi everyone, my name is Marnell Dizon. I'm the training coordinator here at Asian and Pacific Islander Wellness Center, and I welcome you to today's webinar. So, Asian and Pacific Islander Wellness Center is a federally qualified health center in San Francisco, California. We believe everyone deserves to be healthy and needs access to high-quality healthcare. This online platform is supported by funding from the California Department of Public Health Office of AIDS and from the CDC, Division of HIV/AIDS, CBB. Today's webinar is being collaborated with Project Inform. We have David Evans with us today, and of course the community development team here at A&PI Wellness Center. Our team provides training and consultation to capacity building organizations and non-medical providers in California as a part of the California Statewide Training and Education Program, CSTEP, and across the US as part of the CEPA program. Our contact information will be provided to you at the very end, so please stay tuned for that. So without further ado, I'm going to go ahead and put David Evans on, and he's going to talk about our webinar on putting PrEP in context. What do we know now?
Hi, thanks for joining us for the webinar. I want to start out by acknowledging the fact that Project Inform does receive funding from Gilead, who makes Truvada, which is the drug that we use for PrEP. But I can assure you that they actually get no editorial control over what we write, which I think is really important. I want to say a little bit about Project Inform, the organization that I work for. We conduct HIV and hepatitis C advocacy, education, and policy. We've been around since 1985. Our work on biomedical prevention started in 2011, initially in regards to treatment as prevention. Essentially the concept of when a person who is living with HIV has an undetectable viral load, their risk of transmitting HIV to other people drops dramatically to near zero. And we wanted to make sure that the public health response to that was such that people living with HIV would know that information and be able to start treatment right away if they chose to. Immediately following that, we turned to pre-exposure prophylaxis and the upcoming review of Truvada by the FDA. And early on, we knew that we were only going to get limited information. We would know whether it worked or not, but we wouldn't know how to implement it in communities. And so we called in conjunction with a number of organizations for demonstration projects to move forward in a variety of populations so that we would have that information. And some other information about Project Inform: we're one of the oldest companies working on drug pricing and access. That's really important with PrEP because we've been pushing for assistance programs for people who don't have insurance and copay programs for people who do. I am the director of research advocacy. I've been involved in HIV education and advocacy since 1991. And although I had been following the HIV epidemic throughout the 1980s, it really wasn't until I came out that it really kind of hit home for me. And that's because my very first boyfriend, right after coming out when I was 20 years old, on our second date told me that he was HIV positive, and he was only 23. And it was kind of a shock because the perception was it was older gay men who were at risk for HIV and not younger gay men. And as my boyfriend and I looked around to see if people were working on education and activism for young gay men, we found that few people were. And so that was what really drove me to get involved in the beginning. Okay, so the overall topics that I'm going to cover today include effectiveness. So what we have learned about the effectiveness of PrEP in men who have sex with men and cisgender heterosexual women and men. Dosing, so how adherent does someone need to be? How long will they need to take it before it becomes effective? And how long do they need to keep taking it after their risk for HIV stops? We're going to look at acceptance and awareness of PrEP in a variety of communities. What do they think and know about PrEP? And how might that affect their use? What do we not know at this point? We're going to look at rollout, which is how PrEP is being taken up. What are the barriers to access, and how are those barriers changing? And what new strategies there are coming down the line in terms of new formulations of drugs, long-acting drugs, and other delivery methods. So I want to start by distinguishing the difference between efficacy and effectiveness. And the words are so similar that it's really easy to get confused. And so a definition of efficacy is whether a specific intervention, as it is delivered in a clinical trial, prevents disease acquisition in a specific population. So in this case, Truvada, the first study to report was in men who have sex with men and transgender women. It was delivered daily, or people were told to take it daily. And they were followed pretty consistently and given pretty intensive HIV prevention counseling, free condoms, and that sort of thing. So all we knew was whether under those conditions did Truvada lower the risk of HIV acquisition. And in the case of iPrex, which I'm going to talk about in a little bit, it did by about 42% overall. But it's important to keep in mind that that data includes everybody who was assigned to take Truvada, whether they actually took it or not. And that's an important point because in a lot of studies we found out that adherence is really critical, and that when people adhere well, the efficacy goes up quite dramatically. Now, in terms of effectiveness, it's a little bit different. And so effectiveness seeks to determine the degree to which an intervention which has been shown to be efficacious actually prevents disease in a real world public health or clinical setting. So how does it perform under all of the challenges that we might have in a clinic like A&PI Wellness Center? And so just one example of effectiveness would be for PrEP for anal exposure. It was highly effective when taken daily by MSM and trans women, which is the efficacy, but would it work the same or better or worse under different conditions? And we're starting to learn that. For instance, would it work differently when people knew they were actually getting the effective drug, as opposed to the previous efficacy trials where they were told that they might get a placebo and that we weren't even sure whether it would work? So how would that change people in terms of their adherence? And would they adhere well under standard of care conditions? And would their sexual risk behavior improve, stay the same, or decline? So there have been a number of effectiveness studies. I've listed 6 here. There's a 7th that I'm going to talk about that is specific to cisgender women. But the studies that have been listed here are all specific to men who have sex with men, and in one case to transgender women. And those studies are PROUD, which took place in the UK, Ipergay, which was in France, and Montreal, which looked at intermittent dosing, so not everyday dosing. iPrex-Olay, which is a continuation of the iPrex study. The demo project, which was conducted in San Francisco, Miami, and Washington, D.C. ATN 110, which looked at PrEP in much younger men of color, 18 to 22, and the Kaiser Permanente PrEP cohort. So I'm going to talk about each of these. Okay. So some top line results in terms of effectiveness. And this was from the PROUD study. And it enrolled 544 cisgender MSM in the UK. Half of them started Truvada immediately, and the other half were assigned to wait a full year before they started Truvada. So there was no placebo control, but there was a control in that there were half who were actually on Truvada and half who were not. Two things occurred that caused the study to be unblinded early. And unblinded simply means that now the participants knew what was going on, the researchers knew what was going on, the study was stopped, and the people who were in the delayed arm were actually given PrEP. And that occurred for two reasons. One was because the incidence of HIV infection, so the number of people becoming infected in the delayed arm, was much higher than they anticipated. But also, PrEP was found to be more effective than they anticipated. So those two things gave us a very strong early result. And there were 86% fewer infections in the immediate PrEP arm than in the deferred arm. And of the three infections in the immediate PrEP arm, 2 were found to have been in acutely infected individuals who just simply weren't caught before they started PrEP. But in subsequent testing, it was revealed that they were already positive before they started PrEP. And in the third individual, what they found was that the person stopped taking PrEP a fairly long while before they actually became infected. So essentially, in this study, nobody who was actually taking PrEP became infected. Now, that doesn't mean that PrEP is 100% effective, but it does mean that it's highly effective if it's taken regularly. In this particular study, people's risk behavior did not change. It was a high-risk population. People were already not using condoms for unprotected anal sex, and sexually transmitted infection rates were particularly high. And they stayed high throughout the study, but they didn't get worse. However, when they looked at the results, there was a higher rate of sexually transmitted infections in the PrEP takers after the study was open to everybody. And so we are kind of trying to analyze what will be the ultimate impact of that as we move forward with wider PrEP use in the community. Okay. So IPRGay was this kind of anomalous study that was a little bit different because people have been wondering whether if you could take PrEP less often, only around sex, the question was, would it cause fewer side effects? And would it ultimately be as effective, but with fewer meds taken cheaper? And so IPRGay enrolled 401 cisgender MSM in France and Canada. And they received either Truvada or placebo, and nobody knew who was getting which. But it was a kind of complicated dosing scheme. So basically, people took Truvada right around sex. They took a double dose, 2 to 24 hours before they had sex, 1 pill within 24 hours after they had sex, and then a 4th pill another 24 hours later, so 48 hours after sex. What this meant, though, was that for people who were having sex frequently, ultimately they were really getting daily PrEP or near daily PrEP. It ultimately made the study a little bit difficult to interpret because people had a lot of sex. So in other words, a majority of people were in fact taking daily PrEP and not event-based PrEP. But in this study as well, we found that there were 86% fewer infections in the Truvada arm than the placebo arm. Now, France has approved PrEP for use either daily or intermittently, but no other country has yet approved PrEP for intermittent usage. And the CDC here in the United States is not recommending it. And part of the reason is we just don't know for sure whether intermittent PrEP, if it's followed and people have sex less frequently, is as effective as daily PrEP. So there are other intermittent studies planned. We may learn more later. Okay. So IPREX-Olay, as I said, was an extension of the original IPREX study, which found which was the first PrEP study to prove efficacy. And at the end of the study, all the people in the study were offered PrEP, both those who had been on Truvada and those who were on placebo. And of those, 75% accepted the offer to take PrEP. But even in the 25% who did not take up the offer, they were still followed over time. What we found was that adherence was relatively poor, and it got worse over time, especially in younger MSM and transgender women. But on the other side, fortunately, adherence was higher in those who had the highest risk. So it was reaching those who needed it most. Effectiveness was very high despite the low adherence, with 100% protection in those who were confirmed to have taken between 4 and 6 doses per week. So when someone took it regularly, it was highly effective. And I really, again, want to stress that that doesn't mean that PrEP is 100% effective, but it does mean that when you take it regularly, it offers a high level of protection. In terms of effectiveness, older age, a higher level of education, and higher risk predicted better adherence. And in this study as well, risk behavior and sexually transmitted infection rates did not change during the study, okay? So the demo project was a little bit different. Everybody got PrEP. Everybody knew they were getting PrEP. It got rolled out the same for everybody at the same time, so nobody delayed. And this really was the first demonstration project where it was essentially, this is PrEP, it's being delivered exactly how it would be in a standard clinic setting. And in this case, 557 cisgender MSM. And it was initially, they tried to enroll transgender women, but there were no transgender women included. And this included San Francisco, Miami, and Washington, DC. And it was enrolled in 2 cases in a sexually transmitted infection clinic and in Washington at a community clinic, Whitman Walker. The average age was 35, so like with the other PrEP studies in MSM, to that point, it was a slightly older audience. 20% were under 25, which is better than IPREX. And it was slightly more diverse. 48% were white, 35% Latino, 7% Black, and 10% of mixed race. 24% had a primary partner who was HIV positive, and 26% had a sexually transmitted infection at the start of the study, which is a pretty high rate of STI and indicating a high level of risk. Throughout this, at the end of the study, we learned that Black participants and the participants living in Miami were much less likely to have drug blood levels that were consistent with 4 doses per week. It wasn't terrible, you know, nobody, at least 68% of people had drug blood levels of 4 or more doses a week. But white individuals living in San Francisco were much more likely to have higher levels. There were 2 infections in the study that were after confirming that they were actually negative at the start of the study. One had stopped PrEP on his own 1 month earlier, and the other stopped 1 month after PrEP stopped being offered. So in other words, the study terminated, the person was off PrEP for a month, and then they became infected. And the reason I talk about that is that there are access issues that we're going to discuss. So for instance, if someone changed their doctor or their insurance company changed and there was a gap in their insurance, there is the possibility that someone's risk stays high even after they stop PrEP. And so figuring out how we can ensure continuous coverage is going to be important. And once again, in this study, there were no changes in the rates of risk behavior or STIs. And again, both were quite high at the start of the study. Okay. So one of the big questions is whether we could increase PrEP uptake and encourage adherence in those who are at highest risk of HIV, and that is young, cisgender MSM, particularly MSM of color. So 200 18 to 22-year-olds were offered PrEP and followed regularly. 54% were Black and 26% were Latino. Again, sexually transmitted infections were quite common, 22%, and they remained high through the course of the study. Adherence was a challenge. Only half had blood levels consistent with 4 doses per week 6 months after the study started, and that dropped to a third by week 48. There were 3 infections in the study, but none had Truvada detected in the blood at the time of diagnosis. And again, there were no changes in risk behavior through the course of the study. We are trying to do more research in younger MSM to try and understand this a little bit better, and what the barriers and gaps and problems might be. But what I can tell you is that any kind of intervention, whether it's pregnancy prevention, so contraception, treatment for HIV or other diseases, we really struggle with service delivery and adherence in adolescents and young adults. So it shouldn't be surprising that we struggle with PrEP as well. Okay. Sorry, let me move forward here. So the Kaiser Permanente cohort, if you live in San Francisco or other parts of California, you probably know about Kaiser Permanente. It's a closed system HMO in that people get all their services through Kaiser. They don't go to doctors in various doctors' offices. And so Kaiser San Francisco, knowing that a lot of people of their patients were going to want to have PrEP and need PrEP, started a program very early, a PrEP clinic. Overall, just in San Francisco, Kaiser has 176,000 patients. And given the number of MSM and transgender women in San Francisco, the likelihood of a fair number of those needing PrEP is pretty high. So up to the beginning of this year, 2,000 people had sought or been referred for PrEP, and 1,400 are on it. They receive a 45-minute in-person assessment with labs before starting PrEP, and then afterwards do labs but check in via email. So far, since the clinic started about 2 years ago, there have been no HIV infections. There have been a very high rate of sexually transmitted infections. And this is actually was the first study to find that there was an increase or a decrease in condom use among those who were using PrEP in the Kaiser system. In fact, 44% reported using condoms less often after starting PrEP. And I'm going to come back to that in just a minute. So I think it's really important to talk about cisgender women for a minute. There's been very, very little data on efficacy and effectiveness in this population. And in fact, of the efficacy studies that have been conducted in cisgender women, 2 of them had really poor results. And that is because we found that adherence was incredibly low. And I don't want to blame the women. The women are not at fault here. It's really how we deliver PrEP, run trials, and all of the other barriers that they may face, including stigma to receive PrEP services. So I think that there are some structural and psychosocial barriers that we're going to have to figure out. And there's also the hint, which I'm going to talk about a little bit later too, that Truvada may not work quite as well for women if they don't take it daily. So that may be another factor here. But in terms of effectiveness, Partners 2, which was a second study after Partners showed that cisgender women could be protected quite well. They enrolled 1,000 mixed status heterosexual couples in Kenya and Uganda. Either the male or the female partner could be HIV positive, and their partner was HIV negative. And so what they looked at was having the HIV negative partner start PrEP at the same 6 months after their positive partner started taking ARV treatment for themselves for treatment. And the reduction in risk was 98% with only 2 infections, one of which occurred before the HIV partner's viral load was still high. Adherence was self-reported only, but there was good adherence. It is, as I said, the only demonstration project so far in cisgender women for whom condomless receptive vaginal sex is the primary risk factor. There is a demonstration project that is including cisgender women that is currently recruiting in the United States, funded by the CDC, but more information is really desperately needed soon. So we're going to go to some Q&A.
Great. So just so you know, David, we're having a little bit of a difficulty transitioning to the slides. However, everybody who is part of the webinar and who is invited to attend received a PDF version of the slides. So we're hoping that all the participants have that in front of them. We apologize for that. So I'm going to be reading off the question, and people, if you can go ahead and use the chat feature as you hear the responses, and I'll repeat it a few times just because the slides may not be appearing in front of you. So one of the questions that we have here, it says,
Hello? You're frozen on my screen, so I don't know if that's the same for everybody else.
There we go.
Hi.
sorry about that, everyone. David, are you still there?
I am.
I apologize. We had a technical malfunction on our side. It happens when we're live during the webinar. So we're going to try to reboot everything on our end. So we apologize, David. We were trying to get that done as quickly as possible. And I'm just checking the live feed right now. Make sure we're back on. Perfect. So while we're waiting, I just wanted to also make sure that people responded to the questions. I'll repeat it again. So again, if PrEP users use condoms less, this will A, lead to more HIV infections, B, lead to more STDs, C, both A and B, or D, it's complicated. Any responses on the chat for that question so far? Okay, so I got if PrEP users use condoms less, it's complicated, David. What do you say to that?
Yeah, I mean, that's the right answer. And so there are two ways of looking at this. In terms of HIV infections, given that in real world settings, we have not seen an increase in HIV infections, uh, provided that people were using PrEP regularly. And given that we are finding in general in real world settings that PrEP use is that adherence is pretty good, I think we can assume that HIV infection rates are not likely to be more than they currently are, given that people are already not using condoms by quite a bit. When it comes to STDs, I think the situation is a little bit different. With STDs, we probably will see an increase in STDs, at least initially. But one of the things about PrEP is that unlike in the real world, where someone may be asymptomatic and not going for any kind of STD check for, maybe for 6 months or a year or longer, that means that that person is putting a number of other potential partners at risk for getting that STD, which will increase the numbers in the general population, the sexual networks that they have. However, if someone is receiving PrEP and getting regularly tested and treated for STDs, that could actually lead to a lower overall presence of that particular sexually transmitted infection within a given sexual network. So what we might see initially is a bump up. We might actually over time see a downward trend. So that's why it's complicated.
Awesome. So thank you for those who are able to respond. We have actually a couple more questions, David, so I wanted to just go over that with you right now.
Uh-huh.
What's the best way to facilitate buy-in from more healthcare providers regarding PrEP?
Uh-huh. So far, we have seen 3 primary obstacles to PrEP. One of those obstacles is, and in every case, it is either providers feeling uncomfortable prescribing PrEP for a variety of reasons, or just not having the additional services available, such as good STI screening, adherence support, that sort of thing. In terms of reluctance to prescribe PrEP, one of the reasons is they're uncomfortable prescribing an antiviral drug that they don't know a lot about. We're getting more education for providers, so we think that's going down a bit. The other one is people having a lot of judgment about sex and the kind of sex that people are having. The question that a lot of people get from providers is, why don't you just use condoms? Which isn't particularly helpful for many of the populations that we work with. And then the third is even among people who are a little bit more sex friendly and understand this and who have been doing this for a while, they are also worried about an increase or a decrease in condom use and potentially an increase in risk for sexually transmitted infections. And so those are the things that seem to be the biggest concerns about providers. And in terms of buy-in, I think, unfortunately for right now, it's up to the person seeking PrEP, which is not fair, but it is the way that it is. And there are a variety of online resources that if you have a smartphone, you can bring it right into your doctor, including the CDC guidelines. And that's proving to be a pretty effective tool. In some parts of the country, we're actually having public health workers go out to providers' offices and train them in their own offices about PrEP. And that seems to be working as well.
Great, thank you, David. So Again, we're trying to get the slides up, but in the meantime, for those of you who have it in front of you, we're on protective dosing now, which is slide 18. So David, if you could start with that, we can go ahead and move forward.
Sure. So we've actually learned a lot since the PrEP studies were first announced in 2011. It might have been 2010, I'm forgetting. At that point, we knew that PrEP could work, and it worked better if you took it every day. But we didn't actually know how well it worked in terms of adherence. The recommendation was that people take it every day. There was suggestion from animal studies that it could be that you could have lower drug levels and still see protection, but we weren't sure. Now we know. And so the general guidelines that we have for people starting PrEP is that for rectal exposure, a person should take 7 daily doses, or they should be alerted that they need to take 7 daily doses before they have full protection. And thereafter, to take at least 4 doses per week, preferably more. For people who have vaginal exposure, what we've learned is that less of the drug actually concentrates in vaginal tissue than it does in rectal tissue. And so when we do tissue studies, in other words, we take tissue samples from HIV negative people who are taking PrEP. So the amount of drug that's in that tissue is equivalent to the amount of PrEP they're taking. And then we take that tissue, put it in a test tube, and see whether it is resistant to HIV infection. And what we found is that the number of doses in a person's tissue that provided protection from rectal tissue, only a drug level that was equivalent to 2 doses per week in rectal tissue offered protection. In vaginal and cervical tissue, however, you really needed daily dosing for the full 7 days in a week before you saw protection. And so as a result of that, adherence may be much more important for people who have a risk from vaginal exposure. And in terms of when they start PrEP, we recommend that those individuals take PrEP for at least 3 weeks before they are exposed to HIV again. And so basically telling them that they may not have full protection unless they've been taking it that long. The other thing about PrEP is that unlike treatment for HIV, which you need to take for the rest of your life, people have varying periods or seasons of risk. And so people may want to stop taking PrEP. And what we recommend there is that a person continue to take PrEP for at least 28 days after their last risk exposure. There are some researchers who are saying that that could be as few as 10 days. But just to be on the safe side, that is what we are recommending at this point. And if you have questions about that, we can get to them in the next section. Okay, so we're going to talk about awareness and acceptance. PrEP can't get to someone unless they know it exists and how it works, and accept it. So think that it might be a safe and beneficial technology for them to prevent HIV. What we do know is that acceptance of PrEP is growing rapidly among men who have sex with men as information about its efficacy and safety becomes well known, and as PrEP services expand. And what I didn't put here is that the other important point that I think is really important is there was a lot of stigma, slut shaming that happened when PrEP became first available. And that's certainly still there. I mean, we live in a somewhat puritanical society. So sex, in this weird way, we're exposed to all these hypersexual messages on television and in movies and all of that kind of stuff. But we can also be incredibly judgmental about the actual sex that real people have. So I think that is another factor that we are still going to have to get over. It's starting to happen a little bit in certain MSM, but it is still very present, and we really haven't gotten over it in many other communities. But a recently completed survey in California found that 73% of the sample of mostly young gay and bisexual men had actually heard of PrEP, which is a huge improvement of just a few years ago when only 30% had heard of PrEP. But we did find that Latino and Black men and the youngest men were less aware of it. So we have more work to do. Another survey that was conducted among young Black MSM at the time that Truvada was first approved for PrEP, and then again 2 years later, found actually, unfortunately, that there was no increase in awareness. In this case, they also looked at some other levels of knowledge and acceptance. And those who had less knowledge about HIV testing, how HIV was transmitted, and where to go for a test, those who had less knowledge were less likely to know about PrEP. Among gay and bisexual men, when they look at where they heard about PrEP, social media and online sources appear to be the greatest contributor to awareness of PrEP, over and above friends in sort of in-person settings, and certainly from providers. And there's been not much explored about awareness of PrEP among cisgender and transgender women. There's a little bit. Initial data indicates that awareness is much lower, and to some degree acceptance is lower. And awareness among persons who inject drugs has barely been studied, and awareness among trans MSM has not been studied at all. And we're going to talk a little bit about some projects that are now moving forward or soon to move forward to try and address these gaps in knowledge. In terms of, go ahead to the next slide. In terms of awareness and acceptance, other things that we know is that hypothetical acceptability, so me just guessing whether I would take PrEP in the future, is actually a somewhat poor predictor of uptake in new interventions. But it can sort of give us a hint of the kind of research that we need to do. The first PrEP study that was looking at uptake in Black MSM was reported at the Conference on Retroviruses and Opportunistic Infections, we call it CROI, just this past February. It's from a study called HPTN 073. It is being conducted in a couple of different cities, Los Angeles being one of them. And 226 African-American MSM were offered PrEP, 40% of them who were under 25 years old. And most decided to take it, 79%. And when we looked, when we asked them about their PrEP use, 26 weeks later, 68% remained on PrEP and indicated that they were taking at least 2 doses per week. We don't have the drug blood levels to confirm adherence yet. That will be offered in the future. One of the things that we do know, and we don't know a lot about it, the intervention itself, was that the participants in the study were approached by their peers. They were counseled by their peers, and a counseling intervention was designed specifically for this population that looked not only at awareness of PrEP, and adherence to PrEP, but also culturally sensitive messages and referrals for things like job training and other psychosocial services and practical services. So when we can offer a larger suite of services that are relevant to Black MSM, it seems like awareness, uptake, and adherence can significantly improve. Another study was looking at periodic surveys over time in MSM in New York City, and certainly have found an increase of PrEP use, starting at only 2% being on PrEP in 2013, which increased quite dramatically to 14.8% in 2015. Race did not seem to affect the likelihood of PrEP use in this particular sample, nor did age or income. But being uninsured did reduce the likelihood of PrEP use, and decreased condom use increased the likelihood. So again, people at highest risk were those who were most likely to use it. There have been 3 surveys or focus groups among cisgender women indicating moderate levels of PrEP, though more studies are needed. One particular focus group, set of focus groups conducted by NMAC, found that among the women that they talked to, there was almost no awareness, and a significant number of women felt a great deal of anger, in fact, that they had not heard about PrEP, and a fairly strong interest in learning more and possibly using it. And again, data in trans women and MSM trans MSM are greatly needed. This is not mentioned in the CDC's guidance about PrEP. And in the studies, the little bit of work that's been conducted, there are significant concerns reported with gender, I have confirming it should be gender affirming hormones and PrEP, and effect on genital tissue when someone is on either estrogen or testosterone. So that is another area where we need more information. And so looking at PrEP rollout, there are some things that we are learning here. And that is that demand is increasing rapidly in some of the vanguard cities. These are cities that actually conducted some of the PrEP studies or who had already had pretty strong LGBT community STI centers in them. PrEP use has increased by 10-fold or more in a lot of these places, just really in the last year. But barriers still remain, even in those places. We know that few of those most at risk have awareness of and access to culturally competent, comprehensive sexual healthcare services and other services that include PrEP. And it's interesting because Fenway Health Center in Boston has some level of uptake of PrEP among transgender women. And interestingly, PrEP delivery in conjunction with the delivery of feminizing hormones and legal services to help individuals change their driver's license, legally change their name, that having that sort of suite of services does seem to increase contact with and awareness of and acceptance of PrEP in that particular population. So some of the factors that seem to be limiting access include stigma from friends, family, stigma and judgment from friends, family, the community, and providers. And I think that HIV stigma, just in total, is still incredibly strong and affects so many things for HIV positive people and HIV negative people. Lack of health insurance, even though we have the Affordable Care Act and 20 million people, more people are insured now in the United States than they were before implementation. Unfortunately, a large number of states have failed to expand Medicaid. And so the assistance for not just getting the drug, but getting the labs and the doctor's visits and all of that kind of stuff in many states is incredibly difficult to achieve. Even with health insurance, more and more health insurance is incomplete and less generous. More of the cost is being borne by the person who has the insurance policy. And many of them have high deductibles that must be met before coverage kicks in, and high copays and high co-insurance. And co-insurance is when you, instead of when you go to the doctor paying a set $25 or $30 at the pharmacy, you actually pay a percentage of the cost, which could be 25% or more. There's a lack of knowledgeable and willing providers. Again, that's increasing. There's lack of access to regular sexually transmitted infection and lab tests. And oftentimes there's a really low perception of HIV risk. And it's really interesting because this seems to be a consistent theme across multiple populations that continues until today. In that people just simply don't see themselves as at risk for HIV for a variety of reasons, even though they may in fact actually be at risk. And so that may mean that they don't seek out testing or other sexual health services. Okay, and so there are those signs of improvement. We have actually gotten a lot of improvement for people who have insurance in terms of co-payments. And at this point, we can, with a combination of programs, cover almost at least $7,500 a year in copay assistance and deductible assistance, meaning that for a large number of people, they could, in effect, get PrEP for free or nearly free. Gilead has a medication assistance program. We were able to convince them to increase the generosity so that people making roughly $58,000 or less per year who don't have insurance to get them free drug. It's not everything we need. We're pushing for more, but it's a lot better than it was when PrEP first was approved. There are new PrEP clinics and PrEP services expanding even within cities that have low resources. There is increasingly more money from local, state, and federal governments. Increasingly, there are more culturally competent educational resources. And interestingly, PrEP has actually, I think, provided new pressure for the services that we have to be more culturally competent. And there is greater recognition of the need to expand existing PrEP services. The last thing I'm going to cover is new strategies for PrEP. So we had an oral combination of two different drugs, Truvada, and that's all we currently have. And there are downsides with that in that there are some potential toxicities. It is vulnerable to challenges with adherence. Researchers are working on other strategies that might overcome some of those difficulties. This year at CROI in February, we got the first results from a drug called cabotegravir, which is an integrase inhibitor. It's long-acting. Initially, we thought that it would only have to be given once every 3 months. What we found is that the drug actually is taken up by the body a little quicker than we thought it would be, and then eliminated a little more quickly. So at this point, we're looking at every 2-month dosing. So there's a lot of excitement about this particular drug, especially because the systemic side effects like kidney or bone or liver just aren't there. What we do find, though, is injection site pain. So it's delivered as 2 injections in the butt muscle. And people receiving it do report that for some of them there is significant pain. However, when they were asked at the end of the study whether they would like to continue receiving it and whether they would prefer to receive injectable PrEP or oral PrEP, the majority would like to continue and would prefer to receive injectable PrEP. There is a phase 3 study that is getting launched soon in men who have sex with men and transgender women. Again, it will be injection every 2 months, and that will be starting hopefully in the next year. There was very, very early data on a new version of tenofovir, which is one of the drugs in Truvada, called TAF. TAF has fewer side effects. And in this case, it's an implantable. So it is like a little cylinder like they use for implantable contraceptives. And there's the possibility that it might actually last for an entire year. One of the downsides of an injectable like cabotegravir is that once you have it in your system, you can't get rid of it. So if you have problems, you know, the side effects cannot be reversed until the drug is gone. And with cabotegravir, it can stay in the system for months. The other problem is that cabotegravir has a really long tail. So after the last dose, you get, you know, protective levels for 2 to 3 months, and then the dose starts to come down, which means that you can become infected with HIV at the same time as a little bit of cabotegravir is present, which is exactly the recipe for developing drug resistance. So I would become positive, and the virus I have would develop resistance to cabotegravir, which might knock out that entire class of drugs, which is used to treat HIV. So that is a concern with that. With an implantable device, however, if I became infected or wanted to stop PrEP, it could simply be taken out of my body, and I would no longer have the drug in my body. So we're looking increasingly at implantable devices as a possible solution. Another drug delivery device that would work for cisgender women and trans MSM who have vaginal sex would be a ring. And in this case, the first ring results were reported. It is a ring that has to be replaced once a month. It was found to be 54% effective in women over 25 who reported high adherence, leaving the ring in. As with other studies, however, unfortunately, younger women really struggled with adherence. They would take the rings out. There are other rings in the works. And 2 improvements in those rings. One, the vaginal ring that was studied is pretty big, and some of the women not only found it uncomfortable, but they had a hard time getting it back in if it came out. And the other quality of the new rings is that they're actually much more effective at dispersing the drug into the vaginal and cervical tissue. And they can also last longer. So you might only need a new ring after 3 months. There are demonstration projects of oral PrEP happening finally in trans women and trans MSM, and it's actually happening in California. And they will be announced and starting in the coming month or so. They will be looking not only at effectiveness and acceptability, but for the first time, they will actually be doing 2-way interactions of feminizing hormones and the 2 drugs that are included in Truvada. And one of the things that is really important about this study is that previously with tenofovir, which is one of the drugs, we've studied it with hormonal contraceptives, but the type of estrogen used in feminizing hormones is different, and it's given at much higher doses. And one of the concerns is not only how this might affect drug levels of tenofovir, which would affect HIV risk, but also how tenofovir may affect how those feminizing hormones work in the body. And if it significantly diminished their levels, then what should a trans woman do to achieve the results that she wants to achieve from taking those hormones? So hopefully within the next year or 2, we will have firm information to guide people in those strategies. So we're going to another Q&A at this point. And so go ahead, Mel.
We're going to go ahead and put up the question now. So the slides are being shown. And it says, the recommended number of days to take daily PrEP before achieving protection are A, 5 for vaginal risk and 2 for rectal risk, B, 14 for vaginal risk and 5 for rectal risk, C, 20 for vaginal risk and 7 for rectal risk, or D, none of the above. Waiting for some responses to come in. I'm actually getting Uh, let's see here. Mary put in C, 20 for vaginal risk and 7 for rectal risk.
Mm-hmm. That is right.
Great. Cynthia also got the right answer. So thanks everyone for participating in that question. All right. So there are a few more questions that are coming up, but while we're waiting for people to put that up, we have a few here. So let me just get that for you, David.
Okay.
So earlier on, you talked about populations that are not being studied or evaluated, such as people who inject drugs, cisgender trans and trans women, and trans MSM. You're talking about how this population, for some reason, there isn't any studies done on that. But just curious if there's any process or progress being done now that we know that that's an issue, and if you know of any projects about that.
Sure. So let me start with people who inject drugs. One of the things that makes that complicated is that for many people who inject, injection is only one of their risks. They also have sex. And one of the things that we know about people who inject, particularly MSM who inject methamphetamine, is that condom use is remarkably low and sexual risk is very high. So simply getting clean works, which will protect you from your injection risk, is not going to protect you from your sexual risk. So in that case, although syringe exchange has been remarkably effective at reducing the rate of new infections among people who inject drugs, there does still remain these other risk factors. And so I think that the use of Truvada might actually be quite helpful, particularly if they're combined with other services for people serving those populations, such as at needle exchange sites or through methadone clinics or that sort of thing. So that I think experts in those areas are still trying to work out how they actually do that. I think that you know, there's this, you know, it's interesting at there was a presentation at the CDC's prevention conference this last year that looked at how trans people were identified. And what it showed was that if you simply asked one question, which was, are you trans or queer or whatever these other categories are, you got a pretty small number of people that you could identify as being trans. But if you asked a two-step question, which is what sex were you assigned at birth and what gender do you identify with now, it dramatically increased the number of people who were identified as trans. And so one of the problems that we've had with all kinds of prevention studies in the past is that the number of trans individuals is significantly undercounted. And so we know less about risk, we know less about how large of a population they are within communities. And this has led to lagging behind on studies of PrEP. The other thing is there's just been not much trans competence among researchers and service deliverers. And so I think that's been another real obstacle and barrier. And I think that it's getting better. It's going to take more time. But you know, the other thing that my friends who are trans also talk to me about is that getting culturally, you know, trans competent healthcare in general is remarkably difficult, even in a city like San Francisco or Seattle or New York City. So you can only imagine what it might be like in other parts of the country.
Okay, so thank you for that. We have another question that came up and it says, what does data show about the effectiveness of PrEP and urethral tissue for heterosexual men or MSM who only engage in insertive anal sex?
For what kind of tissue?
Urethral, sorry.
Oh, urethral. So the only way I can answer that question is from the partner study, um, uh, uh, both partner studies, which took place in Kenya and Uganda. And in those studies, actually, and the TDF study, which was in Botswana, those studies included heterosexually identified cisgender men. And based on self-report sexual practices, and you can argue about how valid those are, but the men reported that their only risk was inserted vaginal sex. We know that that has a relatively low level risk for men, but it's still there. And we saw a reduction in HIV infection that was pretty substantial in those men when adherence was high. So the only thing I can say about that is that at least for heterosexual men, insertive Truvada seems to work to protect against risk in terms of the urethra or other tissue, particularly in uncircumcised men. Whether that's the same in MSM, we don't know.
And I have another question here. And participants, if you have any further questions, please use the chat feature. We'll do a final wrap up in a few, but I wanted to make sure that we utilize this time with David. The last question I have is, what are some stigmas associated with those who take PrEP?
So, there is actually there are now 3 Facebook groups for people interested in PrEP. There are closed groups, membership groups. You can't just look at them. You have to become a member of the group. One of them is a number of years old, since 2012, that has 14,000 members. It has largely been MSM. There is a newer group for trans MSM that is online, and one is set to be launched for cisgender women. And these are more informal places for people to learn about PrEP. Interestingly, in the MSM group, there are people who are very anti-PrEP. And one of the stigmas that still exists is that it is not okay for people to desire to have sex without a condom, that it's morally wrong. Given all the tragedy and horror of the epidemic. One of the other stigmas is that it's not okay for HIV negative people, for resources for PrEP to be diverted from HIV positive people. So that was one of the concerns or judgments. But in general, I think, as I mentioned earlier, regardless of who it is, whether it's cisgender women, trans individuals, MSM, cisgender MSM, I think there is just a lot of judgment about sex. And people who have more sex with more partners of a particular type are judged pretty harshly by their peers, by society at large, by their family, certainly, by their providers. And so that's a big issue. And I don't exactly know how to solve that, except to increase awareness, to have frank discussions. And, as with HIV, there was such a huge fear and stigma, especially at the beginning of the epidemic. And what really made a difference was having people living with HIV be out about their status, and talk about their status and talk about what it meant to them. And, talk about the fact that, you don't have to worry about touching me or sharing a utensil with me or all those other irrational fears that society had. And I think that's getting better. Interestingly, a good friend of mine who is an HIV positive activist, longtime activist for women, she conceived a child with a straight male partner about 10 years ago. And when she went to her OBGYN to talk about that, her provider said, if you decide to do that, I will no longer see you as a provider. You're going to have to find someone else. When it became more knowledgeable among some of her friends and family, there was this tremendous judgment about how could you possibly put a baby at risk who would be born positive. Even though there was incredible data saying that if she followed guidelines, the likelihood that her child would be infected were almost no. And she just experienced so much judgment. And when I talked to some women who are going through conception today, there seems to be less judgment. Although interestingly, we are using PrEP to help HIV negative women have babies with their positive partners. And so I think we're also seeing this other sort of judgment come alive for a different category of women.
Great. So I'm looking here, I don't see any further questions. So what we're going to do while we are waiting for any last minute things to pop up, David, is we're going to move forward to final thoughts and wrap up with the webinar.
Sure. The final thoughts are, there's the fear that PrEP introduction, again, will reduce condom use and that may turn out to be true. But the lack of HIV infections in studies so far is very encouraging. The fear of STI rates going up, it actually may be hard to measure for two reasons. Particularly in MSM, rates of syphilis and gonorrhea and chlamydia have been on the rise since the early 2000s and have continued on an trajectory. And even though we are seeing a continued increase, it's really difficult to correlate that with PrEP. The other thing that makes it complicated is that if you're testing more often, you're going to be finding more STIs. And so it makes it even more difficult to link PrEP use with an increase in STD. So I think it's as we talked about, it's complicated. I think we need to increase pressure on local, state, and federal agencies to do more to expand PrEP to cisgender women, transgender women, and then genderqueer people and to people who inject drugs. And I think that, I want to say that that pressure has been effective in some cases. So for instance, the California HIV research program funded by the UC system was one among the first to fund some demonstration projects on PrEP. And the first round were all MSM, cisgender MSM. But there were a lot of complaints that one of the biggest needs was to understand PrEP in trans persons. And they succumbed to that pressure. And they offered requests for proposals to do research, initially just in trans women. But again, there was a push on them to include trans MSM. Because even though there's very, very little data, there is reason to believe that they are at a pretty heightened risk of HIV as well. So those studies are going to be open to trans MSM, and so we'll hopefully learn more. And we need to press our city, state, and federal governments to increase PrEP where people may most benefit from it. And we're trying to figure out how to do this. One of the issues in California is that in big cities like Los Angeles or San Francisco, who get a lot of direct funding from CDC, who have large city and county budgets, HIV budgets, it's been a little bit easier to provide PrEP services than it would be if you live in Kern County or more rural areas of the state, or even farther away in the Bay Area from where PrEP services exist. So I think we need, as individuals, to support and increase advocacy to really get other government officials to step up to the plate. So that's it. With that, I want to just highlight the fact that we have at Project 5 printed materials on PrEP. You can order free copies. You go to projectinformed.org/PrEP and you get access to them. We have a booklet called Is PrEP the Right Choice for You, which is for both cisgender and transgender MSM. We talked to a lot of transgender MSM to find out whether they wanted their own specific booklet. And, you know, resoundingly, they said, no, we see ourselves as men and MSM. And we would simply like for you to revise your booklet that would be inclusive of language and information that would be relevant for us. We have a booklet that has been around for some time that we collaborated with women's prevention organizations and advocates. It's called PrEP, A New Option for Women for Safer Living. We have an article called Transcending, or a booklet called Transcending Barriers for Safer Pleasure, which was written in conjunction with transgender women, and it is for transgender women. There is a booklet on how to get PrEP, so how to get ready for a doctor's appointment, the kinds of information you need to bring in, how to figure out about insurance coverage. We have a PrEP flowchart on Access, which is our most requested piece of information from providers across the country, and a pocket point of access card. So those materials are available. And then on the next slide is contact information for myself and Murnell.
Great. And again, if it's training related content that people are asking, wanting to have questions on in relation to PrEP, please contact David. His email is up there. If it's like training logistics or how you can get more of this information as far as our webinars go, please contact me. So we are really excited, David, that you're able to join us today. We're going to also include the link to these 5 resources on our archive. So once we archive this webinar, your slides as well as this link will be provided. So we don't see any further questions, so we are making really great time. So I just want to take a moment to, again, thank you, David, for taking some time out of your day to present the updates on PrEP, and to thank our participants for joining us for this time frame. And if you have any other ways to wrap up this presentation, David, now would be the time, and then we're just going to close it out a little early.
No, the only thing I would say is that, you know, if you find yourself, or if you're in the position of providing PrEP services, whether it's just education or awareness or anything, and you're finding trends either in how people perceive PrEP, obstacles they're running into in terms of trying to get it or pay for it or that sort of thing, please do contact me, because we do have ways of trying to advocate around those issues and remove barriers. So that's the only thing I would say.
All right, great. Thank you again, everyone. We're just going to go ahead and end it here. We hope to see you again in future webinars. Have a great day. Thanks, David.
Thanks.